And I think we would move on, and I would like to introduce our first invited speaker for today. And that is Professor Karim Lekadir. He's a senior researcher at the BCN MedTech Center at the University Pompeu Fabra in Barcelona. He received his PhD in computing at Imperial College London. He was a postdoctoral researcher at Stanford. His current research focuses on the development of data science and machine learning approaches for the analysis of large-scale biomedical data. Noteworthy, especially for this event, he's a founding member of the AFRICAI, the African Network for Artificial Intelligence in Biomedical Imaging. And he's also the general chair of the MICAI 2024 conference, which is the first time that MICAI will go to the African continent and will be held in Morocco. So I'm really looking forward to your talk, Karim. I hope you're there. You can now join the stage and share your screen. And we're really looking forward to your talk about another great initiative, which is the Future AI initiative. Thank you.
Thank you, Ben, for the introduction. Can you hear me well?
Perfect, and we can see your screen.
Fantastic. Okay, thank you, everyone. Thank you for the invitation. It's a pleasure to be here. It's a privilege to give this talk about an initiative in which several actually of the audience members participated in and provided ideas and feedback. And it comes from the observation that there is a lot of output, research output in medical AI, in particular also in medical imaging, which increase every year exponentially. And the question is how much of this will be translated and deployed to benefit patients. This is an interesting website that is maintained by the American College of Radiology of the list of all FDA cleared AI solutions in medical imaging. I recommend that you have a look at it. At the moment, last time I checked, there were 201 AI tools in the database covering different organ systems and different tasks. And I should emphasize that these tools are FDA cleared, which means they are comparable to something that exists in the market, but they're not approved, which means they didn't undergo an advanced evaluation of the AI algorithms. This is some examples of AI tools in the database for liver imaging. There are a lot more for breast imaging, because there's a lot more data in breast imaging. So there has been a lot of research, and there are also a lot of tools that have been developed by the community and the industry. And there is a distinction between the low-risk AI, so for example, segmentation tools. These tools, I would say, are already used in clinical practice. Why? Because the clinicians can verify the results and can correct if there are errors. So they are really useful, these tools, because there's an enormous gain in productivity for clinicians, but low risk because the clinician, they have control over the results. Now, what happens with other types of tools concerning, for example, diagnostics or treatment planning? So I'm sure you've seen these examples in the media. So there's a lot of hype around AI and a lot of promising tools. But the question is how many of these AI tools are deployed and used in practice? And I think this is where we start talking about trust. How much of these tools are trusted? And the concept of trust is something that we can find for other areas of medicine. For example, for the COVID-19 vaccine. So the level of trust in the vaccine was very low at the beginning and continued to be low month after they were introduced, as shown by this study from Imperial College London. And it took some time that the trust in these vaccines increased. And the same happens with AI. We do need trust in these tools so they can be deployed and used. That's why some agencies and authorities, for example, the European Commission, set up an expert group that actually worked on this topic, on the topic of trustworthy AI. And they identified a number of criteria that trustworthy AI solutions should comply to. One of them is diversity, non-discrimination, and fairness, but also there's human agency and openness, technical robustness and safety, and so on. They came up with a document in which there is a lot of recommendations, And additionally, these recommendations apply to AI in general. They didn't make any distinctions between different domains of application, even though AI in medicine is different from AI in other areas, for example, in cybersecurity. So there is a need, I think, for more work to define trustworthy AI in medicine and also in radiology and medical imaging. So this was a statement of multiple associations and societies across Europe, United States, and Canada. They wrote that the radiology community should start now to develop codes of ethics and practice for AI, which promotes any use that helps patients and the common good. So indeed, we do need a code of practice, and such code of practice exists for other areas that are relevant for our communities. For example, a code of practice on how to manage data. So this code of practice, I'm sure many of you have heard of it. It's called the Fair Data Management Principles, which states that the data should be managed such that they are findable, accessible, interoperable, and reusable. And these are the guiding principles and the guidelines. So there are a few. There is a website, gofair.org, and data generators and managers can go and follow these guidelines, so the data is managed in a certain way that would benefit the community. And in fact, the European Commission has estimated that the cost of not having fair research data is 10 billion euros. So there is an incentive, and in fact, now the European Commission promotes these guidelines. There are other guidelines that have been developed in related to AI. One of them is on how to report the AI studies. So this is the claim guidelines, checklist for artificial intelligence in medicine, a guide for authors and reviewers. So this is guidelines on how to write basically papers and what to include in the paper related to AI in medical imaging studies. So for example, the study design, the data, ground truth, data partitions, model training, evaluation results, and even discussion. There were also some proposals for guidelines on how to evaluate AI solutions in healthcare. So this is one that was proposed recently in Australia, and this is another one that was proposed in the United States. And they have different proposals, but the same goal, which is to promote good practices when evaluating AI solutions to increase trust. And this is why we came up with the idea of developing guidelines that are consensus across stakeholders, but also international. So instead of having these guidelines, some of which in different continents, some actors in the field got together, starting with a number of European projects, to discuss new guidelines that for trustworthy AI in healthcare. And we invited stakeholders from all the continents, and who gave us a lot of feedback and ideas on how to come up with these guidelines for trustworthy AI in medicine that would be useful and applicable. I should add that these stakeholders are AI scientists, but also clinicians, social scientists, ethicists, and so on, to have a diversity of opinions. We call them future AI because we think trustworthy AI solutions should be fair. They should be universal, that means generalizable, for example, across sites. They should be traceable. It's possible to monitor them over time and see whether the performance is maintained. They should be usable by end users. They should be robust, obviously. And of course, they should be explainable. Future AI. So I will go through the 6 guiding principles, and I'll tell you what are some of the recommendations that we provide. This is one of the first papers we read and actually inspired us in this work. This was published in Science, which showed an algorithm, this time not a research algorithm, but an algorithm that is actually used in clinical practice in the United States, was discriminating against Black patients when referring patients to a higher level of care. And it showed that fixing this disparity would increase the percentage of Black patients receiving additional help from 17.7 to 46.5%. I'm not going to go in detail through the other examples because Andrew just explained them and gave you actually very, very nice examples. Just as another one that showed how existing deep learning algorithm, as they are, the baseline implementation do involve some level of bias and fairness. This is an interesting paper that estimated the number of data sets used to train deep learning algorithm in medical imaging in the US that showed that most of the data sets came from 3 states only, and that half of the states did not contribute any training data set at all in these papers. So this is one of the causes of unfairness in machine learning for medical imaging. So these are the 4 recommendations and we came up with. So we wanted to keep a minimum set of recommendations to have something that is easy to follow and also that is useful, and also to give some flexibility to the developers of future AI solutions. So the first one is that the definition of fairness should be compiled for each application at the design phase. So this is important. Fairness differs between AI applications. And there are the traditional categories such as age, sex, ethnicity, and socioeconomics, but there are also application-specific categories, and these need to be understood, discussed, explored, and defined at the design phase before even starting to develop AI solutions. So, for example, in the case of breast cancer, we noticed that there was a risk of bias against high breast density cases, as low breast density cases are the vast majority in existing databases. I would like to give you another example to tell you how important it is to have this discussion and this dialogue with the experts before even starting implementing the techniques. So we wanted to develop an AI tool in cardiology. And we spoke to some hospitals here in Europe, particularly in Barcelona. And they told us, well, they don't have data, multi-ethnic data, so we could test fairness of the algorithm across ethnicities. So they suggested that we contact a hospital in Peru. There they have interesting multi-ethnic data sets. In particular, they have a Black population, a native population, what they call a mestizo. They even have populations, ethnic groups originating from Japan. And when we spoke to them, we thought that they would say, well, indeed, this is important and ethnicity is important. But what they told us, and that's what I would like to insist, that this should be done on an application-specific basis, is that what they thought would be an important source of bias in Peru is the altitude. So there are people who live at 5,000 meters and some who live at sea level, and the lung capacity of the hearts differ significantly. So that's why this recommendation is important. It's an important, I think, practice that we should all adopt to discuss fairness at the very beginning of the project. The second recommendation is that training and testing data should be collected together with subject characteristics such as age, sex, ethnicity, and so on. This is not always possible. This is not always easy. Sometimes the data protection regulation does not allow it. But when it is possible, this is a major benefit to later on assess bias and fairness. The third recommendation, it's an obvious one, but it's worth emphasizing it, that AI algorithm bias should be evaluated systematically. And when there is bias, it should be reported. And we see papers and AI products all the time that are developed without actually evaluating bias. So this is also a practice that we should all adopt. And finally, when biases are identified, the application of bias mitigation methods should be considered. And Andrew gave you some example of such list of mitigation measures. So this is for fairness. I'm going to go quicker through the other ones because this is a workshop on fairness, but the other principles are also important, and there's a lot of research to do that. So I hope you can get inspired from these ideas I will develop and I will present. because there is indeed a lot of work to be done. So, for example, for universality, here the idea is to develop tools that can generalize. And this is a paper that showed that a tool trained on a large database in one hospital, over 100,000 individuals, could not generalize well to another hospital. So that's why it's important to check this as well. And here we have some recommendations. For example, that the AI model should be systematically tested using external data sets, and that the medical AI tool should be clinically evaluated in multiple clinical sites. And the use of standards is also useful, to develop tools that are interoperable and can be deployed in multiple sites. Traceability, this is an interesting paper that was developed that was published a few years ago about a breast cancer screening tool by Google Health that was evaluated in the United States and in Britain. It's a very, very promising result. However, it was also criticized. Actually, some called it useless because there was a lot of lack of detail in the description of the algorithm and the models. So some experts in the field wrote a paper on the need for more transparency. And why do we need traceability? Is also because there are phenomena such as data drift and concept drift, such that an AI algorithm that works today may not work in 1 year or in 2 years. Traceability is also important so we can know the origin of errors when errors occur, and so we can understand the responsibilities and liabilities and improve accountability. Hence, we recommend that detailed information about the AI tool should be specified and documented, but that after deployment, the AI tool should be continuously monitored for errors, data quality, and so on. And after deployment, the AI tool should be periodically evaluated and adapted, maybe every 6 months, every year, and so on, to check whether the performance is maintained or whether there is a degradation in performance that there is a need to update the model. Usability is an important element because an AI tool could be of very, very high quality, but if the end users do not like it at the end, they will not use it. This is a survey that was performed across multiple centers with multiple clinicians that showed that actually clinicians, the vast majority, do believe in AI. They think it will improve their field of medicine. But at the same time, the vast majority have never used AI in clinical practice. So we need to increase the usability of AI tools. And for that, we need to have a dialogue with clinicians in particular, but other clinical end users, including patients, at the design phase to understand what are their requirements, their needs, their preferences, maybe the obstacles in terms of the interfaces as well, and so on. That there is a need for user manuals, and that clinical usability should be assessed in the real world with end users, something that is not done all the time. I think we should learn to work with clinicians at the design phase, but also at the evaluation phase. Robustness is something that we are more familiar. I think there have been a lot of work to increase clinical robustness. This is an example that shows how changing machines can reduce the robustness of an AI tool. This is also an important work that showed how even small changes to an image in a way that cannot be seen with the naked eye actually can lead to complete different AI prediction. So if this changes, this noise could be introduced through adversarial attacks. This could lead to harm for the patients. Therefore, to increase the robustness, we need to train our models on representative data. We should also test them. And it has been recommended that the AI tool should integrate a mechanism from human oversight and feedback. And the European Commission in particular has recommended this. So they recommend that the tool should not be fully autonomous, but there should be always a degree of human oversight. Finally, explainability. This is also an area where there have been a lot of research. Nevertheless, there are articles regularly that show that there are still limitations, and sometimes these explanations that are provided by existing techniques are not clinically meaningful. So we recommend for explainability that the need and the method for AI explainability should be defined again at the design phase. Maybe explainability is not needed at all, for example, for segmentation. And if it is needed, we need to show this method, this existing method, maybe using dummy examples or toy examples to the clinical end users and clinicians, so they could tell us which method they may be more comfortable with or maybe more appropriate. And then the evaluation study should include the evaluation of explainability with end users, for example, to estimate the explanation goodness and also satisfaction, whether it improves the confidence of the end users, whether it improves their decision making. Finally, we also recommend that medical AI tools should associate a confidence score to their output, so we can understand what these predictions mean really and whether we should follow them. So I would like to give you an example to finalize this presentation. This is an EU-funded project that is based on the future AI guidelines. It is called RadioVal, International Clinical Validation of Radiomics Artificial Intelligence for Breast Cancer Treatment Planning. And it has several partners and hospitals from Europe, but also it has a hospital in Argentina, another one in Egypt, and another one in Turkey, to have an international multi-ethnic evaluation of these AI solutions for breast cancer treatment planning. The clinical motivation is that breast cancer has become the most prevalent cancer in the world. It surpassed lung cancer in 2020. But there are important disparities between countries, including within Europe, both in terms of prevalence, but also in terms of mortality. So the clinical motivation again here is that treatments such as neoadjuvant chemotherapy are promising, but the selection of the patient that would respond to these therapies are category-based, and there is a lack of personalized medicine approach. As a result, there is a relatively low success rate. For some subtypes, it's extremely low. And at the same time, side effects are massive, a lot of toxicity, but other problems such as hypertension, infections, and pains, and so on, and also mood disorders. So we would rather avoid it. There's also high costs associated to it. So AI-based patient selection for chemotherapy in breast cancer would increase the success rate and prevent side effects for non-responders. And radiomics solutions have been developed over the years, in particular using breast MRI, and they are very, very promising. But there is a large body of work. These are some examples. However, are they trustworthy? Would someone trust these tools despite their promise to actually translate them and use them in practice? So, well, let's look at the different principles. So as I said, in terms of accuracy, it is promising up to 0.85 accuracy in some cases. But the fairness has never been validated. We have never seen it in any of these papers, so we don't know if they're fair. Universality, we found a couple of studies, one testing the tool in 4 Chinese hospitals and one study in the US and Canada. Traceability has never been validated, usability neither. Robustness has been validated to a certain extent, and explainability never. So how do we now validate these different principles and criteria in our project? So for fairness, what we did is, first of all, we wanted to minimize the inclusion criteria. And at the same time, we had this dialogue where we spoke to the different experts, and we are continuing this dialogue so they could tell us what are the different potential sources of bias. And that's why we decided to include first and previous history of cancer as criteria for the selected patients, non-metastatic versus metastatic, low versus high breast density cases. So this is important also because, for example, high breast density are underrepresented, and often they also correspond to certain ethnic group. For example, we included patients with previous aesthetic breast surgery in this evaluation. And then we estimated the number of evaluation metrics, as Andrew explained before, and we also implemented and evaluating a number of meditation measures. So this is a work that is ongoing across the different clinical sites. Project that started recently, but this is our plan. For universality, we decided to select 3 hospitals in high-income European countries, in Spain, Sweden, and Austria, but also 2 emerging European countries, Croatia and Poland, and 3 low to middle income countries, Egypt, Argentina, and Turkey. For traceability, we are developing what we call an AI passport that provides all these different detailed information about these AI tools to increase transparency. We will also develop a new radiosmics monitoring tool that will provide information on data quality and failures, including a human-in-the-loop mechanism for human oversight, a dashboard with time series visual analytics and alerts. We'll have also a comparable system for periodic evaluation. This is important. So we will check every 6 months, every year, whether the performance degrades or is maintained. This is how it will look like a little bit. So we'll have this visual analytics that will show the performance over time. We'll have a module to detect data drift to compare a reference distribution to future distribution of the data, and so on. For usability, so here we will work with clinical end users. We will work with 2 radiologists at each site. We are working with 2 radiologists. So we started this, 2 oncologists, 1 multidisciplinary team with 6 members, an oncologist, a radiologist, a pathologist, a surgeon, radiotherapist, and a data manager, with diversity in experience, gender, and so on. And we will have all sorts of questionnaires to ask them to provide us feedback on the usability of the tool, whether they find them useful and user-friendly, and whether it improves their productivity, and so on. For robustness, we will check robustness with respect to different imaging protocols and also different scanners. And we will also evaluate a number of mitigation measures, for example, image harmonization and so on. For explainability, we will assess explainability with the different end users that I already mentioned, but also we are talking to them at the moment. We are showing them dummy examples of existing techniques, trying to explain them using accessible, intuitive examples, what sort of method exists and which ones would be more appropriate for them. Finally, I should add that in addition to the 6 principles, we have a general category where we have other recommendations, because the 6 categories are not sufficient. For example, we recommend that these tools are developed with interdisciplinary stakeholders, that they are developed while ensuring data privacy and governance, and that application-specific ethical risks are investigated and defined again at the design phase and throughout the development of the AI. So in terms of user engagement in this project, the RadioVal project, I already mentioned different stakeholders, but we also are talking to psychologists, for example, that may give us some interesting feedback and ideas on how to develop these tools in a way that they will be trusted by the clinician, but also the patients. So there are other stakeholders that we're talking to. It's a highly multidisciplinary validation study. In summary, Future AI is a collaborative work to define consensus guidelines for trustworthy AI. They focus on medical application, but they apply to medical imaging as well. The approach is interdisciplinary, holistic, and the guidelines are compact. We decided to have a limited number of recommendations that are easy to follow, but those that are sufficient to actually guide the development teams through these different criteria and dimensions that are important to achieve trustworthiness. Finally, the guideline is dynamic. We have a website and we welcome suggestions and feedback all the time. This is very important, and we think the guidelines will change over time. They will be different in 5 years because the area is advancing and the evidence will also evolve. So this is the website, and just like to acknowledge first funding from the European Commission, funding through this RadioVal project, but also the contribution of all the different experts from all continents. So we are over 80 experts that provided feedback and ideas and discussion, so we were able to come up with these guidelines. And I would like to thank you for your attention, and we'll be happy to answer some questions. Thank you.
Thank you, Karim. That was a very comprehensive talk. Let's all thank the speaker again. I guess from the internet and speaking for the whole room. Thank you, Professor Lekar, for such a wonderful talk. Please post your questions in the chat. While we do, I'm going to ask what the final poll question, so the Ben Glocker question. Do you feel overall, so you presented quite a comprehensive talk, but do you feel overall that the opportunities of machine learning and the medical field in general, but medical imaging outweigh the risks? Do you feel there are more opportunities or more risks, or we have yet to see?
Yes, thank you for the question. Indeed, it's an important one, and it's related to the one we had at the very beginning of the session. And I tend to be from those that believe that these are all opportunities. And so to give an example, when I started hearing about traceability, I was kind of worried that we had to sort of consider the fact that AI is dynamic and changes every now and then. But then I realized this is an opportunity to develop tools and methods that can sort of adapt the tool over time, adapt the tool to new data sets, that also to assess and identify data drifts and so on. So I think there will be a gold mine of opportunities to develop new techniques for all these dimensions, including fairness and the other criteria as well.
Okay, yes. I personally had a follow-up, but I think we'll actually switch to chat now. Aasa has a question. Explainable AI is still an immature field, which does not live up to the expectations needed for safe AI. How do we bridge the recommendation of trying to make explainable AI work with the reality of it not working to satisfaction yet, without losing public faith in AI entirely? So really, like, perhaps there's a question, how do we manage expectation and our own research development, or the public interaction that's required with explaining what we're doing?
Yes. Yeah. That's actually a difficult question. Maybe that shows that we are not still there. We're not yet there in terms of trustworthy AI, and explainable AI is an example of one of the dimensions where there are still limitations. So all I can say is that first of all, we need to continue working and acknowledge these limitations, because it's true that sometimes we read these papers that we have the impression that they solve the problem, but the reality is that we're still not there. But I would add that we do need now evidence. We really need evidence. We need studies on explainable AI with end users. So I may put in the chat an example of a study that was published in Ferrante that I liked a lot, because they really went into the trouble of validating their explainable AI techniques with end users, with clinicians, and by looking at different dimensions, even their mental state, how they felt while using the explainable AI solution. And that's convincing. If we can have such evidence, I think the public will have more faith in AI eventually on all these different dimensions.
Yeah, that sounds great, and I would love to read it. And I'm sure many people also in the chat would love to read it. Aasa says thank you as well. But I think it's fascinating here that user and practitioner have been separated. Or sorry, user is the practitioner and patient is separated. So now user is not always patient. But looking at the clock, this is where we normally thank the speaker again. And I'm sure the Zoom room is quite appreciative, even though we're virtual. So thank you for speaking.
Thanks.
Next up,
Thank you for the invitation again.